All right, good afternoon, everyone. I was starting to get a little panicky because my Zoom wouldn't load. Thought I was gonna have to restart my computer or something. Luckily for all of us, Zoom loaded so we can talk about menopause. Did everybody have a good spring break?
Yeah,
I know Ernesto was training, weren't you? You get all your training in?
yeah. I worked, but I went skateboarding at least like once. So
Okay. Skateboarding sounds fun.
yeah, yeah.
Thomas decided he's having his birthday party at a roller rink, so we're doing some roller skating we're rolling into six
Awesome.
because his mom is such a nerd. She likes to what's the most creative thing I can say on the invitation?
But that's pretty good. I will never like come come with something like that.
The P1s told me that Puerto Rico was beautiful over spring break, that the weather was like 85 degrees, and that they really enjoyed the nice weather compared to here. Is that true for the P2s who went back to Puerto Rico?
Yes, he was.
Did you get any beach time in, Christian?
Yeah, yeah, one day.
One day.
We have a lot of PT, so I try to study the most as I can. So
Okay. Study at the beach?
I was obsessed at that sunscreen, so I have no evidence of going to the beach, but we made it.
Well, I am so proud of you for using your sunscreen because that is something that I did not do until I was too old. And now I'm kind of um insane about it. We had because the sun is so hot here in Colorado, so we use a lot of SPF clothing.
Same thing. Like for us in Puerto Rico was not a thing until I started seeing a lot of my aunties and my both of my grandmas having skin cancer. So I'm a freak. I hide from it, but I think most of the exposure that I'm gonna have for my entire life, I already took it. But oh well, too late.
Same. Same. Yeah, I highly recommend the SPF clothing because there's not enough reapplying that I can do here in Colorado to prevent myself from getting burned. So, got the big hat, long sleeve stuff. Jessica, did you do anything fun?
Yeah, I actually went to Puerto Rico. So,
What?
yeah, I hung out with Haiti. So she
Oh,
showed me around. That was fun.
that does sound fun.
Yeah.
Well, I'm glad you got away.
Oh, definitely needed it.
Yes. All right. So we've talked a lot about like the development of women and a lot about pregnancy and what it takes to prevent pregnancy, what it takes to get pregnant, what we need to do for patients when they are pregnant. We are moving on beyond the reproductive age and we're going to menopause today. So this will kind of end out our like life cycle of the women of the woman today. And then the next couple of weeks, the rest of the class is mostly special topics and how they affect women. So we have Dr. DiGiaco coming in next week, who's going to talk about substance use disorders in women. We're going to have a work day for your PSA. So please make sure that, I believe that is April 2nd. Make sure that you are ready, or April 1st. Make sure that you are ready to work with your groups on your PSA that day. Everybody has 2 hours blocked off because they're supposed to be in this class to work on the PSA. That would be maybe a good time to video it. I will be available on Zoom hanging out if you have any questions and need any help with anything that day. But otherwise, that is a work day for you to be with your group and get the video done. We have Dr. Gald coming in from AstraZeneca to talk about the differences between men and women in respiratory disorders. Her and I met last week to talk about the lecture, and it is some of the things she told me blew my mind. Like I didn't even know. It was very fascinating. Um, so you'll be able to talk to her about respiratory disorders, and then she'll also she works for AstraZeneca. So if you're interested in industry when you grow up and graduate, she's willing to take questions on industry after she does the lecture on respiratory disorders. We have Dr. Ong talking about eating disorders in women. So a lot of exciting things, a lot of exciting topics coming up here. Are there any questions or concerns about anything that we have going on before we get started with today's lecture? Okay, so we're going to talk about how women change from perimenopause to old age. So we're going to talk about perimenopause, menopause, and old age. We have a list of objectives for you to focus on. We're going to talk about the psychosocial and financial impact of caregiving, empty nest, divorce on middle-aged women. We're going to talk about the differences between perimenopause and menopause and the symptoms associated with them. We're going to talk about the differences between urge incontinence and stress incontinence. Recommend appropriate treatment options for vulvovaginal atrophy. Talk about osteoporosis. We're going to talk about the psychosocial and financial impact of retirement or widowhood and senior women. Differentiate between services provided at an assisted living facility and a skilled nursing facility. And then talk about the consultant pharmacist role in geriatric care. So broad range of topics. We're all over the place today. So we've talked about women. We've talked about women as they enter adulthood and they start their menstrual cycle. We've talked about contraception and fertility. We've got up until this point. Now we're getting into the midlife, and this is what we consider the sandwich generation. So you have kids that you're caring for, and you have parents that you're caring for. So that's the sandwich generation. You're caring for your kids and your parents at the same time. You can also have empty nest syndrome, and this is where your kids grow up and move out of the house. And so now you don't know really what to do with yourself because your life centered around your kids for so long, and you don't have any hobbies or anything for yourself. So empty nest syndrome, don't really know what to do with your time and being able to sleep through the night. Dr. Matthew said that, because she has a new baby, and she said to me, she's like, at least your kid sleeps through the night. I was like, no, he does not. Ever since we moved to Colorado, he thinks that there's a ghost in his room and he wakes up almost every single night. So even at almost 6 years old, I'm not sleeping through the night yet with my kid. I could be a little bit more stern with just put yourself back to sleep, but then that results in crying and fussing and a longer time to calm down. It's just easier to tell him to climb in bed and go back to sleep within the next 20 minutes because I'm an old parent and I don't have the stamina for that kind of arguing in the middle of the night. We do see in midlife women and men getting divorced at a higher rate because when you don't have those kids tying you together and you're not staying together for the kids, divorce becomes a little bit more prominent in that midlife cycle. And then you move into perimenopause in the 40s and menopause in the 50s, typically speaking. After that, we hit retirement, widowhood, and why we're having retirement and widowhood, because women typically live longer than men. We start getting physiological changes like the urinary incontinence, the vaginal atrophy, the osteoporosis that increases our risk for morbidity and mortality. We have various financial challenges and health challenges. So this is what we're going to focus on today, because the first part of the class was this. So this is where we're going to focus. Looking at social determinants of health as it relates to midlife and old age, we have to think about whether a person has access to health and healthcare, their economic stability. So how are they being supported? Are they still working? When they're retired, where is their income coming from? The social and community context, this becomes really important, especially as we get into that elderly age, and people in the widowhood. Do women have the social and community support that they need to live happy and fulfilling lives? And talking about the neighborhood and the built environment. So a lot of times we'll see the elderly population move into assisted living facilities or nursing homes, and that helps provide that neighborhood and that built environment. So there's a lot of factors here that go into the health of a person who's in their midlife to old age, there's a lot of factors that go into anybody at any time and whether they can obtain the health that they want, right? Access to care, health literacy, those things are still important too, but these become more prominent in midlife to old age. So entering midlife, it's not a midlife crisis, it's a midlife recreation. So we get to recreate ourselves and kind of figure out who we are in midlife. So what are some challenges that middle-aged women may face? We've talked about a few of them. What are some things that you think that middle-aged women face? Maybe you think about your mom or your grandma, depending on how old you are and how old your mom and grandma are.
Like physiological changes, like they they don't produce as much estrogen, so that can like produce like osteoporosis and other things, and also psychological, I think, changes.
Okay. Yeah, definitely physiological changes, especially as that estrogen comes down. Everybody feels better most people feel better when their estrogen is at a higher level. So when the estrogen comes down, we start getting physiological changes. Excuse me, osteoporosis being one of them, increased. That more happens in kind of the elderly, not necessarily the midlife, but it does start happening in the midlife. We have the psychological issues that can be related to decreased estrogen, but it can be, again, related to some of the things that are going on. Sometimes if you've had kids young in life, as you're hitting midlife, as you're hitting 50, 60, your kids are getting out of the house. If you had kids when you were older, then your kids are still with you. So you could have the empty nest, but you could also, with more women having children later, when they get to midlife, they still have teenagers at home and their parents are becoming elderly. So again, you have that sandwich generation that can affect the psychosocial aspect. So again, the sandwich generation is raising children and caring for aging parents simultaneously. The average age of a caregiver is 49.2 years old. Higher burden is on women to be the caregiver. We see this through all phases of life. Oftentimes, we see that the wife is the one that chooses to stay home with the family and raise the family. The daughter is the one who is chosen or self-chosen to help with the aging parents as a caregiver. So we do see about 75% of all caregivers are female. And then besides the caregiver being female, 50% more time of a female person is being spent on caregiving than male. So even if you're not the primary caregiver, as a female, you're still typically providing 50% more caregiving to those in need around you compared to your male counterpart. As you can imagine, your children and your parents have very different needs, right? So that can lead to a lot of stress. It can lead you to neglect your own health. It can lead to social isolation because you have to take care of your kids, you have to take care of your parents, and where is the time for you to take care of yourself? And it can have a psychological toll because you're dealing with a lot of challenging issues on both ends of the spectrum there.
Does this pace seem familiar? For so many of us, the everyday routine can feel like a game of beat the clock. Squeezed between children struggling to grow up.
Come on, George, gotta go.
And parents struggling to age with dignity.
Good to see you.
Welcome to the sandwich generation. Bob Turner left for work well before dawn.
Georgie.
But for 57-year-old Jeannie Turner,
Wakey, wakey, eggs and bakey.
this is just a typical day. A tug of war between time, love, and money.
Time to get up, buddy. School day.
It's just 6:30, but in 15 minutes it'll be time to leave for school.
You don't get much sleep.
No, 2 to 4 hours a night.
So if you're in the sandwich generation, which part of the sandwich are you?
I'm in the middle. I'm in between the bread and the meat.
1 in every 8 baby boomers between the ages of 40 and 60 is both raising a child
Gonna have a good day today?
Hope so.
and caring for an aging parent.
That's a great picture of you and Henry on your wedding day.
And it's because of 2 things. Boomers are opting to have children later in life, while at the same time, their parents are living longer lives. Hence the squeeze. It's both emotional and financial.
So do you lie awake at night? Or are you
Yes.
looking at the clock?
Kind of a panicky feeling sometimes.
The greatest trials for me is taking care of that second family of children and my mom is a time away from my job.
So here's Bob Turner, selling printing jobs on 100% commission.
And I'm used to working 7 days a week, 10 hours, 12 hours a day. And then all of a sudden finding I couldn't work that. My income went down.
Dropping from a cushy $180,000 a year to just $80,000. And the 401k, the IRAs, they've all but disappeared too. Even the family's rainy day fund has been tapped.
Who prepares for a real emergency? You know, that sneak up on you. A parent that's 94 years old that's in a nursing home. Kids that are teenagers that are very costly.
Now it's high noon, and Jeannie is heading out to visit her mother-in-law, Bernice, the beloved matriarch of the Turner family. Bernice outlived her own finances years ago. Her living expenses and medical bills drained a fair chunk of the family savings. Now a stroke has put her permanently in a nursing home. Jeannie and Bob make it a point to see her every day.
Are you tired? Are you going to go back to bed? Are ya?
Adding to the pressure of being caregivers is the stress of navigating the complicated and convoluted language of Social Security, insurance policies, Medicare, Medicaid.
It's all about paperwork. I have learned that Medicare and Medicaid change, and they change their policies. And unless you keep up with that, the bills never stop coming in.
It's late afternoon when Jeannie starts to get dinner together. Her thoughts never far from George and Shea, the children Bob and Jeannie adopted 12 years ago, who are costing the couple a lot more than they ever expected. But love doesn't have a price tag, especially in this case.
They were both severely abused. They were homeless. Both the children have bipolar disease, and our daughter has reactive attachment disorder, a very, very serious mental illness. We go to psychiatrist once every 3 months, psychologist once a week, and have for 12 years, and we pay out of our pocket for that.
Shea is currently serving time in jail on felony charges, an outcome of her mental illness. Sometimes life's choices seem less sandwich, more vice grip.
We're trying to get her mental help, which is very difficult. It's all almost too much. I'm sorry.
Wondering who will be there for them as they age. Jeannie and Bob are learning the hard way how to best prepare for the unknown.
Organization is key. Just legal things have to be in order. You need power of attorney. You need medical power of attorney. You have to have your bank statements, your birth certificate, if your spouse died. Nothing will get done unless you have these records in play.
It's the sandwich generation for which this is especially important.
Memorial parks, burial plots, headstones, all the things that you don't want to talk about when your parents are alive are things that are really important to have in play in case something, God forbid, should happen.
Good to see you.
It's 6:45.
Good to see you.
A rare moment to relax with family and friends.
Cheers.
Reaching out for support is crucial. Sharing the good times.
Great expectations. Hey, all right, Bill.
And the not so good with people who understand.
I think it's the only way to get through it, is to have a support system. Friends, family, neighbors, whatever it takes.
A sense of humor doesn't hurt either.
We always tease people that we'll be working when we're 90. Walmart, if you need a greeter, here we are. I'm never going to give up. So tomorrow I'm going to take Georgie to school. I'm going to go to the nursing home to see your mom.
Meanwhile, the clock is ticking. It's getting late. Time to get organized and get some sleep. For the sandwich generation, tomorrow starts early, as usual.
Right. So looking at the financial toll of caregiving, when we're looking at, and this is specifically as it relates to women, 29% of them pass up a job promotion, training, or assignment because that would interfere with their caregiving role. 20% of women switch from full-time to part-time employment when they take on a caregiving role, whether that be having a child or having to take care of a parent. 16% of women quit their jobs becoming a caregiver, and 13% retire early from their jobs if they need to take on a caregiving role. So we have a patient case here. FG is a 70-year-old female with hypertension, hyperlipidemia, COPD, heart failure, and arthritis. She is no longer able to live independently. FG has 3 adult children, 2 daughters and 1 son. Her daughters take time off of work to care for her, and she expects them to prepare her meals, do her cleaning and laundry, and drive her to the store and appointments. Her son states he cannot take time off work because of his high-paying job and implies that it is more important than their jobs. FG expects the majority of the caregiving to come from her daughters and not her son. She is happy if her son calls her once a week and visits her monthly. The situation has caused tension in the family. Let me know what you think the primary issues are here and what could this family where could be some options for this family to help balance responsibilities. So think about that, put it in the chat. A lot of good comments here in the chat. Anybody who has lived through this with their parents or grandparents knows how tenuous these situations are for families. All right, so some things that have come up is that the expectation from FG that the daughters do most of the caregiving is a lot to put on the daughters. Some other people have said maybe creating a schedule for them to all take turns so that the caregiving responsibilities can be split equally, or potentially hiring outside help to help with the caregiving to help lighten the load. Maybe placement in a facility, because maybe if the daughters are doing so much caregiving that it's not appropriate for her to be living at home right now. So yeah, a lot of good thoughts here. My mom was a primary caregiver. My mom retired and then became the primary caregiver for her mother about 6 years ago. And that put a lot of strain between her and her 5 brothers and sisters, because she was doing a lot of the work and they were just coming in to say hi and how are you and check a box. Put a lot of strain on my mom. And then particularly got worse after my grandma passed away. That really blew up the family dynamics. So these are tricky situations, especially for people who don't have financial resources to get outside help or to put them in a skilled living facility. Because as you saw in the video, Medicare and Medicaid are very tricky to work with to get them to pay for various services. All right, so empty nest syndrome is feelings of depression and grief when children move away from home. This is not a clinical diagnosis. This is a transitional period. So you're not going to find empty nest syndrome in the DSM-4. So please don't go ask Dr. Ong what the DSM-4 criteria is for empty nest syndrome. This is just a title for a transitional period. All right. Women are more likely to experience this than men, again, because more often than not, women are doing the majority of the caregiving, and their worth is tied up in helping take care of the children. And now the children are gone, and that sense of worth has kind of diminished. And then they're also going through things like menopause and caring for parents at the same time. So it's a total, mind trick for women. Going through all these transitions at one time. You have changes with your identity, you have changes with your activity that you do and your routine. There is a higher impact on women who are stay-at-home parents because their work was directly tied to their children. But there are some benefits to empty nest syndrome. So things like there's reduced work because you don't have all the caregiving responsibilities at home anymore. There's decreased relationship conflicts. I don't know any of you who are parents and co-parent, whether in the same home or separately, but co-parenting can be very challenging because we all grew up in different homes with different parenting styles, and we all default. Like our natural tendency is to default to how we were raised. And, I make a conscious, not that I was raised badly, but I make a conscious effort to do some things differently than my parents did. And trying to, get rid of some of those behaviors that aren't helpful or the best for kids. And I work really hard at that. But again, there's a lot of conflicts with parents on how we parent and how we respond to kids. And a lot of that comes from our family of origin and how we were raised, right? So if we're not having to care for kids, we get decreased conflict because we eliminate that source of conflict. We're not like, should we let him have dessert with his dinner or after his dinner? Like, should we let him stay up and watch another episode? Like, those types of little conflicts can fester and build up in families. So you get, and that because you have less caregiving responsibilities, you have time to improve the quality of the marriage or the relationship, and opportunity to pursue hobbies and careers after that. But we also see the divorce rate for people 50 and older doubling since the 1990s. So 1 in every 4 divorces is considered a gray divorce. So they have gray hair. They're over 50. The top 10 reasons top reasons for divorce in patients who are older, and those gray divorces are verbal, physical, or emotional abuse, different values and lifestyles, cheatings, fell out of love, or had no obvious problems. Impact of divorce is not benign. You can, even if like divorce, you wanted the divorce, or it was the best thing for the relationship. If the divorce was the best thing for the relationship, you still experience loneliness and depression, issues with self-esteem or self-confidence, a sense of failure potentially. And people who divorce have higher levels of depression than those who are widows. So that does say a lot about the mental toll of divorce on people. There's a huge financial impact for women who get divorced, especially if the woman took time off of work to be a caregiver. So it can be very hard to financially support yourself after a divorce. Excuse me. If you get a divorce and you have not been working, you don't have a 401k or a 403b or a retirement plan, and you're getting divorced later on in age, so there's no time to build that up for yourself. You may or may not, depending on the state and the divorce decree, get some of your spouse's retirement, but it's not guaranteed. But you don't have your own either, potentially, if you've spent all that time caregiving. So divorce can have a pretty heavy financial impact on women, especially women who don't work outside of the home. So in 69% of heterosexual marriages, the man earns more than the woman. And this is true even in my household, where my husband has a high school education and I have a doctorate. He still makes more money than me. But he volunteers to give up his life for the country, and there's no way I would do that. So I guess there's trade-offs, right, to everything we do. So again, if you're going to get divorced, you are not making as much money as your spouse. That will impact your standard of living. That can impact your health insurance and your retirement, because you might not have as good of a health insurance package at your job. So the standard of living decreases by 45% for women and only 21% for men who after divorce. And then women after divorce have a significant negative impact on their credit scores. Their credit scores decrease more after a men's divorce. Oftentimes, women have to finance their divorce lawyers on credit cards, high interest credit cards, and they have no way to pay them. So that can significantly impact your credit score. Women have to take time off of work for caregiving and childbearing, and that can, or child rearing, and that can impact the divorce more for women. And again, like I was talking about previously, women, if they haven't been working, they have less time to recover when they're getting divorced earlier, because they don't have time to recover that 401k, that 403b, that Roth IRA. So women over the age of 63 who had a gray divorce had a poverty rate of 27%, which is worse than widows. So if you're getting divorced in your 50s and 60s and you haven't been able to work outside the home and invest in your own future, you are at increased risk of being in poverty after the divorce as a woman. If you remarry, that can help lessen the financial blow of divorce potentially. So, this is a woman's health course. So all you women, start investing as soon as you can while you're working. The sooner you invest, the more money you'll make in the end. So make sure you have your own stuff. If you decide to be a stay-at-home parent, make sure you set up some kind of Roth IRA for yourself, some kind of investment plan for yourself. I hate to talk negatively because everybody thinks when we get married that it's going to last forever, but we can think that it's going to last forever, but still plan for a future. And then even if you don't get divorced, you can then you'll have that money to have a really nice retirement life together afterwards. All right, so thinking about health in patients, we are talking about perimenopause, menopause, and genital urinary issues. So we're switching gears a little bit from the financial impact and the psychosocial aspect and moving into kind of the clinical of what's menopause. So menopause results because of aging ovaries. So I think people like to describe it as your ovaries are shriveling up. Right? I don't know that really happens, that they shrivel up, but women are only born with so many eggs. As we run out of eggs, our ovaries are aging and not functioning properly. Menopause is considered if you've gone 12 months without having a menstrual period. So that is key here to being diagnosed with menopause, is that 12 months have passed and you have not had a period, you are officially in menopause. And that's without contraception impacting that, because if you have an IUD for various reasons, if you're still taking contraception for various reasons, you cannot have a period. So this would be a period without any medication intervention to prevent the period, okay? For 12 months. The average age of menopause is 51.5 years old. So, the pathophysiology in our reproductive years, we learn that we have FSH that stimulates the follicles, and the follicles release estrogen to get that LH surge, which release the egg at ovulation, where you can get pregnant, and that you get an increase in progesterone. But in perimenopause, which means peri means around menopause, so around the menopause time, you get that increase in FSH, but you have fewer follicles to stimulate, right? Because women are only born with a certain amount of follicles. Once those follicles are gone, they're gone. So you have less follicles to stimulate. So you're getting less release of estrogen and until you eventually have no follicles to stimulate and are not getting that release of estrogen. So the end result is you get an increase in FSH and LH and a decrease in estrogen, right? So this is before menopause, where we're up and down, up and down, up and down, right? That's the PMS happening, the PMDD happening there, up and down and up and down, in a pretty predictable pattern for most patients, except for maybe patients with PCOS or endometriosis, that their cycle might not look like this. We get into perimenopause and we are all over the place. So some people that argue that perimenopause is worse than menopause, because you don't even know what's going on with your body. Your hormones are all out of whack. And then menopause, you have a significant decrease in estrogen that does not recover. So perimenopause, again, peri is around. So around the menopause time, you have increased FSH and you have irregular menses, but you still have a menstrual cycle. Menopause is you've had no menstrual cycle for the last 12 months. Other things that happen during this time include hot flashes, osteoporosis, loss of libido, night sweats, mood symptoms, hair loss, vaginal dryness, urinary symptoms, weight gain, sleep disturbances, and depression. So it's no wonder that women in perimenopause or menopause feel absolutely terrible. Thinking about other things that can happen in this menopause age, you get the urinary issues. So you have an increased risk of incontinence, which is the involuntary leakage of urine. The prevalence of incontinence increases with age, especially women are more likely to be impacted than men, especially women who have had children. This is the urinary incontinence issues are often underreported because most people don't want to go talk to their doctor about peeing their pants, right? Like, I'm an adult, I shouldn't be peeing my pants. That can be really hard to talk about. The outside of women having children and putting pressure on their pelvic floor and decreasing the tone of the pelvic floor, you can have the bladder and the urethra have estrogen receptors. So if you have decreased estrogen, that will shrink the urethra and cause urinary incontinence. So the genital urinary issues with women in older age are twofold. You have the decrease of estrogen, which that shrinks the urethra, increasing the risk of urinary incontinence, and then you have the issue with the pelvic floor as it relates to childbearing. So there are 5 types of incontinence. Stress would be like if I'm laughing too hard, or if I jump, or if I cough or sneeze, that would be stress incontinence. um, uh, not to put my mom's friend, I have some, so I worked in a pharmacy when I was in high school, and my mom worked in the pharmacy with me. And so she worked with these women in the pharmacy for 30 some years, and they've become like my pharmacy moms and friends. And so I see them every time I go home, and we make sure that they come over to the house or whatever. And they all talk about wearing their biggest pads when they come over for lunch because they know that there's going to be so much laughing and so much stress incontinence because they're all in their 60s. And I'm glad that they're open and sharing that. But this is what women go through. Like what size pad am I going to wear because I'm going to be laughing or I'm going to be doing an activity where I could have urinary incontinence, right? Urge incontinence is if you've seen the commercials, but nobody watches commercials anymore. But if you did see the commercial, it would be the gotta go, gotta go, gotta go, gotta go right now commercial. For like, it used to be for Ditropan and Detrol LA. So you can look those commercials up. But it's like you feel like you have to go all the time, even if you've already went, you feel the urge that you have to go, that you haven't cleared out. You have overflow where your bladder just cannot relax enough to allow it to fill up, and it overflows by going out of the urethra and out of the body. You can have mixed, and then you can have functional, which is things are just not working properly. So stress, I already talked about what all these are. I get ahead of myself on this lecture anyways. So stress incontinence, again, is when you're sneezing, coughing, laughing, lifting heavy objects, jumping around. This is a factor with pregnancy and vaginal delivery. Another thing is that it is also a factor with C-section because you're cutting into those muscles too. So people who say they have a C-section are like, oh, my bladder's fine. And then they find out that no, their bladder's not really fine because we've cut through those muscles. And can happen in menopause, and it's more prevalent during menopause than it is post-menopause, right? We can treatment, we have incontinence products, so the pads. Pelvic floor training is very important. If you are pregnant or after you recently have a baby, I highly recommend that you get pelvic floor training, pelvic floor physical therapy. It is one of the best things you can do for yourself to help prevent this post-pregnancy. Just because it's common doesn't mean it's normal. So just because you have urinary incontinence after you have a baby does not mean it's normal. Just because everybody talks about it doesn't mean it's normal. So just because something is common doesn't mean it's normal. And pelvic floor physical therapy is one of the best things that we can do for stress incontinence. We can do, if the patient is menopausal, we can use topical estrogen therapy because, again, giving them more estrogen for that urethra to lengthen out so that there's not so much pressure on that urethra. It has a longer track to go down. Could also use potentially duloxetine, which is a SNRI, serotonin and norepinephrine receptor a drug. But one of the things, the best things is the pelvic floor training, pelvic floor physical therapy. So urge incontinence, this is I gotta go right now. This can happen in males, but it's more common in females. It can happen because of pregnancy or childbirth. This is another thing that pelvic floor physical therapy can help with because it helps you retrain your brain, especially after pregnancy and childbirth. It happens with menopause and aging. It can happen with obesity or patients who have cognitive impairment. For this urge incontinence, we're going to use muscarinic agents, so anticholinergic drugs, which means that these drugs will cause
dry mouth.
Yes. Can't spit. Drowsiness. Excellent. Can't pee. Yeah, so we're using these drugs for the side effects, right? Can't see, can't pee, can't spit, can't. So the anti-muscarinic, anticholinergic. So we have oxybutynin, which is the most common one because it's the most it's low cost, high value. I used to say cheap, but look at me improving after working at the insurance company. It's low cost, high value. We have solifenacin, tolterodine, which is also another popular one. Tolterodine is the Detrol or Detrol LA. A little bit less anticholinergic side effects than the oxybutynin. And then we also have mirabegron or Mybetriq. This one can increase your blood pressure and heart rate, so you need to be mindful of that. Okay, so entering old age into the golden years. So what do you think are some challenges that can disrupt your golden years?
Economical.
Economical, yep.
I would say also maybe solitude if you have like a structured family or a support, group, or because I've seen people in their golden years there are alone, and it's pretty bad for them.
Yeah, definitely. As you get into the golden years, people start dying, your friends start dying, so you start losing your support system. If you don't live close to especially if you don't live close to your family and have them readily accessible. So you do get some of that isolation potentially happening, or if your partner passes away and you become a widow, that can increase your isolation. And then you start getting health effects too, right? Like health issues become more challenging for you. Okay, so looking at the physiological things that can happen in the golden years for women, we have vaginal atrophy. This starts happening in menopause, and you start getting loss of elasticity and shrinkage of the vaginal length, and you get a thinner epithelial lining. So if you're losing elasticity and it's shrinking, and you're getting a thinner epithelial lining, that can lead to dryness, itching, burning, pain with sex, malodorous discharge, or urinary symptoms. So this is one of the things that a lot of older women that bother a lot of older women. As we can see, it's prevalent in about 40% of most postmenopausal women. If you're having pain with sex, then you can also have reduced libido, because if it's painful to have sex, then why would I want to have sex type of thing. So that leads into this cycle that can lead into relationship problems, right? Because you're having changes in the pH of the vagina, you get changes in the bacteria in the vagina that can lead to higher lactobacilli, which is increases the acidity of the vagina, which increases the growth of essentially yeast, Candida albicans, and other bacteria. All right. So how do we treat this? We can use lubricants. We can use moisturizers. We can use dilators to help with this. Most women would prefer to use some kind of estrogen. So you can use systematic estrogen. So this would be your Premarin, which is your conjugated estrogen. Do you know that conjugated estrogen comes from pregnant mare urine? That's where the name Premarin came from. Pregnant mare urine. Fascinating, right? Anyways, so we can use systemic estrogen, but we generally try to avoid this because patients, especially older patients, can be at increased risk of venal thromboembolism, so that DVT, that PE. And if we're giving unopposed estrogen, we can have issues with our endometrium, leading to increased risk of endometrium cancer. And systemic estrogen can worsen stress incontinence. So we have a balance here, like between treating the vulvovaginal atrophy and making other things worse, right? You can do the transdermal patches, gels, or sprays. These don't have first pass metabolism, so they have decreased risk of the blood clots compared to the systemic estrogen, and they don't increase the triglycerides as much as the systemic estrogen. The things that you're going to see most commonly used are the topical estrogen vaginal products. So this is a cream or a tablet that you insert locally right into the vagina. You don't have to worry about the unopposed estrogen, so you don't have to worry about giving progesterone because it's a low dose. So we typically see creams and tablets used inserted into the vagina because it has more of a local effect than it does a systemic effect. And we don't have those, we have lower risk of VTE and other things like that. Vaginal rings, we do have to be careful about because they have higher estrogen doses. And so those can have the risk of issues with our endometrium. So we may require progesterone with them. We also have this estrogen agonist antagonist, I can't say that. And so, this helps with estrogen agonists in the vaginal tissue. So it promotes only working in the vagina, and it's antagonistic in the endometrium. So this is wild that we can get an agonist in the vaginal tissues and an antagonist in the endometrium. So we don't have to worry about the unopposed estrogen because this drug only works in the vaginal tissues. I don't think we see a lot of this used. I would expect that it because it's very high cost, low value. And so it might be inaccessible to patients because we're thinking about vulvovaginal atrophy in patients who are older than 65, have Medicare, have that coverage gap, or donut hole is what we used to call it. So I don't think this drug is really accessible to patients. But it's weird to see something that's an agonist and an antagonist, right? Like, how do you develop a drug that is an agonist in the vaginal tissue and an antagonist in the endometrium? We see an increase in urinary tract infections in elderly patients. And this happens because of the vaginal atrophy. So we have increased bacteria in the vagina that can translocate into the urinary tract very easily because your urethra, also your vaginal cavity gets shorter, your urethra gets shorter. So there's less transit for the bacteria to translocate and get into the urinary tract and cause an infection. We see incomplete bladder emptying. We can see poor hygiene just because it can be hard to take showers and clean yourself if you don't have the proper support. We see prolapse, which is where essentially your bladder starts falling out of your vagina. So that's super fun, right? If a patient has a history of UTIs, and then diabetes can increase the risk of urinary tract infections. So if a patient is postmenopausal, they might not have very specific symptoms of a urinary tract because our bodies change and react differently to things. So any person who is postmenopausal and has frequency, urgency, or intermittent pain with urination needs to have a urinalysis to evaluate for a UTI. We want to get a urinalysis and make sure that they have a UTI, because if we're overusing antibiotics, that can also be dangerous to elderly patients. Thinking about tendon ruptures from using levofloxacin or ciprofloxacin, thinking about C. difficile, and then being more sensitive to the disruption of the bacteria in their body. Thinking about cognitive effects. A lot of the fluoroquinolones can have CNS effects, and patients that are elderly are at increased risk for CNS effects. So only wanting to use an antibiotic if it's really necessary. So next we have osteoporosis, and this is low bone density. If our bones become less dense, then it increases the risk of them breaking. We diagnose this with a bone mineral density scan or a DEXA scan. It's more prevalent in women than in men. About 80% of Americans with osteoporosis are women. If we think about the bone and how it works, we'll talk about this more in renal when we talk about bone mineral density orders, but the bone is constantly being built and reabsorbed, and this process is normally balanced. We build it, we reabsorb it, we build it, we reabsorb it, recycle, and it's usually balanced. Osteoblasts create the bone, and osteoclasts reabsorb the bone. And that process that's usually balanced is regulated by the parathyroid hormone, calcitonin, estrogen, vitamin D, and cytokines. So it stands to reason when we hit menopause and we get a decrease in estrogen, we get a decrease in regulation of that process. So that process doesn't become balanced anymore. So we'll see, this is what a healthy bone looks like. That is all dense in there. And this is an osteoporosis where you see more air pockets, which means that it's less strong, increases the risk of breakage. We see osteoporosis in the spine where, people start getting that hunchback. You've seen the little old ladies at the grocery store or in church with the little hunchback. That's osteoporosis happening. All right. And when our bones aren't strong and we fall or twist the wrong way, we can get a broken bone, and that can be deadly in elderly patients. Like, the morbidity and mortality is very high if a patient breaks a hip. So in that postmenopausal osteoporosis, we see a lack of estrogen because we don't have any follicles to stimulate, so we're not producing that estrogen. And that leads to an increase in osteoclast proliferation. So we get more osteoclasts, and osteoclast is what breaks down the bone. So we get more cells that are breaking down the bone, and they're living longer. So we get a lot more breakdown of the bone than we do of the osteoblast activity, which is building the bone. Blast, build, class, break down. And because of the decreased estrogen, we also get increased excretion of calcium. So we're not hanging on to the calcium in our blood as much as we normally do. And we need calcium to play into this cycle. And if we're not hanging on to enough calcium, then that's also contributing to this cycle not being balanced, because we need calcium to build the bones, for the blast to build the bones. All right. So after age 80, you lose 1.6% of your bone density per year. That is pretty high compared to 0.5% after 30. So after 80, patients at 80 are at the most increased risk of osteoporosis. We have issues with our PTH and estrogen getting out of whack. We have issues with calcium absorption and vitamin D deficiencies. So then we get increased fracture risk. So what can patients do to help prevent osteoporosis? Well, smoking cessation is always the right answer. Limiting alcohol intake, making sure you have a balanced diet with adequate vitamin D and calcium intake, having weight-bearing resistance exercises, and then fall prevention. So what is balanced calcium and vitamin D? For women 50 and younger, calcium is 1,000 milligrams a day. For women 51 and older, it's 1,200 milligrams per day. Calcium, you can only absorb so much calcium at one time because it becomes saturated. So you have to take your calcium in doses of 500 to 600 milligrams. So that's why if somebody is on calcium, they should take 1 tablet twice a day or 1 tablet 3 times a day. Because you can't, if you took all 3 of those tablets at one time, you'd still only absorb 500 to 600 milligrams and you need 1,200 milligrams. All right. For most people, if they eat dairy products, green vegetables, and fortified cereal, they only need to do 1 tablet twice a day for their calcium requirements. Vitamin D, everybody who does not live on the equator is vitamin D deficient. And as that was a great conversation that Jose, Yvonne, and I had about sunscreen, leading us into this, that even if you were to go sit out in the sun, you would not make enough vitamin D because people are like, oh, I need the vitamin D. That's why I have the seasonal affective disorder. I'm not getting enough vitamin D from the sun. I'll just get my vitamin D from the sun. Like, no, if you do not live on the equator and you do not have regular exposure to sun, you are not going to make enough vitamin D from being out in the sun. Also, being out in the sun increases your risk of skin cancer, which can be very serious. And then a lot of things that we're doing between the sunscreen, the SPF clothing, and things like that limit our ability. So it's best to get your vitamin D from your diet. And so it can be very difficult to get it from the diet alone. But fatty fish, milk, our milk that we buy in the store, not the raw milk that the people are touting on social media right now, but the milk that we get at the store is fortified with vitamin D for this reason. Our cereals are fortified with vitamin D. Vitamin D is fat soluble. So that's why when you see people who are vitamin D deficient, they get 1 capsule like once a week or once a month because it's fat soluble. So once it's built up, it hangs around. But if you're going to recommend a calcium product for a patient, it should be a calcium plus vitamin D because you need the vitamin D to absorb the calcium. And here's a little extra tidbit. You're paying me what, $50 an hour. So I'm going to give you some information that's worth $51 an hour right now. If the patient is older, above 60, they have less acidic stomach. So you should be recommending a calcium citrate product for them because calcium citrate does not require a acidic environment to be absorbed. Calcium carbonate is the most common calcium product out there, but calcium carbonate requires an acidic environment to be absorbed in. And most elderly patients don't have an acidic stomach to absorb the calcium carbonate appropriately. So you should be looking for things like Oscal, which is usually calcium citrate. Now, when you go out on your IPPEs or to your internship and somebody asks you which calcium product is the best, you can tell them with confidence. All right, so psychosocial changes as the patients get into the golden years, thinking about that retirement, widowhood, nutritional challenges, and long-term care. Retirement pensions. So pensions are very much a thing of the past. There's very few jobs that offer pensions anymore, which is why people don't stay at jobs for 30 years. Like both of my parents worked at their jobs for over 30 years. They never switched. My mom got a pension from the hospital when she retired. A lot of the people who worked in the car industry used to get really good pensions, or in factories. We don't. You're most likely not going to see a pension when you go out and get your job after you graduate. So don't count on that. All right. But this is the employer makes a contribution to a pool of funds, and they're set aside for the worker to use in the future. That pool of funds is invested, and the earnings provide income to the worker when they retire. Again, you're not going to see pensions very much anymore, but people of like my grandparents' age and my mom have a pension. But that pension is for the person who worked, not for the person they're married to, all right, or their partner. And so we see here some corporate lobbying was like, let's get rid of these pensions and switch to a 401k. So now all the risk is on the worker and not on the company. So that's what, in 1978, we see the 401k's development, which that requires you to do your own investment and for you to put the money away yourself. And your employer is not responsible for that. So women generally had lower incomes and spent less time in the workforce when pensions were very prominent because, again, they're child raising, they're child rearing, they're child bearing. And so they're working typically lower paying jobs and taking more time off. The other thing is that many women lived longer than their spouses. All right. So older men were 1.7 times as likely as older women to receive pension, so almost twice as likely to receive a pension than a woman. And the median pension earnings was 71% higher for men than women. Right? Divorce, a pension earned during marriage is considered a joint asset, and the state courts decide how that's divided up. And then most pension plans provide a survivor benefit to the widow spouse, but as a lot of them require you to opt in, and this costs money to do a survivor benefit, and you don't get as much as the person who earned the pension typically. So if my